Hello, and welcome to the Cass Health Podcast, the show where we hope to connect our community with healthcare information that's relatable, understandable, and useful to your life, and where you get to know better the neighbors providing your care here. I'm your host, Carter Anderson, and in today's episode, we'll be talking about Jiffy Knee surgery with orthopedic surgeon Dr. Todd Sekundiak. Before we get started, two quick disclaimers. First, the comments in this podcast do not necessarily reflect the views of Cass Health. Second, the information in this podcast is not intended to be construed as personal medical advice. Always consult your primary care provider with your questions and concerns regarding your health. Welcome. Thank you so much for taking some time to chat with us today, Dr. Sekundiak. And since this is kind of your first episode with us here on the podcast, I wanted to ask you a couple of fun get-to-know-you questions to kind of break the ice a little bit. So we'll start with, where are you from?
So you might pick up that I talk a little bit funny because I actually grew up in Canada in a place called Winnipeg, Manitoba. I did a lot of my training up there and then finished up here in the United States. I married a fourth-generation Omahan, so I've kind of been down here ever since.
That's what I wondered, what the connection was there, so that's funny. Had you grown up there in Canada most of your life, your younger years?
So kind of was a late bloomer and saw the light. I actually did practice within the Canadian healthcare system, so I've kind of seen it all. But I feel very fortunate and very proud to be part of the Cass County team now, too.
What's your favorite go-to exercise or activity? Way to kind of get moving a little bit.
Well, I'm getting long in the tooth also. So I used to love jogging, but even now I've had to give that up because just like my patients, I get some of those knee complaints and strains. So I've had to kind of go to a lower impact activity. So it's not that I like exercise, but you feel you sometimes have to do it just to keep yourself mobile.
Absolutely. Do you have a favorite sports team?
Yeah, talk to my wife and my kids. I'm not a big pro, sports fan just with the money, the politics. My son does love the Jays, and so I would admit that I'm a little bit of a Creighton Blue Jay fan.
There you go. That's a good team to be a fan of right there. They're good stuff. If you're cooking dinner to impress, what are you making?
I'm making a credit card that takes my family out for dinner. So it's weird. We probably go out for dinner more than we're supposed to. The problem is when we cook at home, someone's always cleaning, someone's always going to watch TV, and, someone's already done. So we do love that sit-down meal where everyone's kind of together, and sometimes just going out for a quick bite's the best way to do it.
Right. No other activities, dishes, anything to get in the way. There
Exactly.
You go. I love it. Driving alone in the car. What are you jamming out? Do you like music, podcasts? What do you kind of listen to on your commutes?
So I'm kind of boring. I do like music, but I think that one side of my brain's not completely developed. So I'm kind of more of a news guy. And to get just kind of a whole worldly view of what's going on, I listen to this channel called BBC. So it's the British news, but it kind of gives a great world perspective of, everything that's going on in the entire world, not just in our little local realm.
Right, a little more globalized and I'm sure a little more broader spectrum.
Yeah, a little less dramatic.
Right. Do you have a favorite holiday or one that kind of rises above the rest for you personally?
Yeah, I'm a Christmas guy.
There you go.
So it's pretty fast and easy with that one. Everyone gets together. The weather is not the greatest at that time of year, but it gives you a reason to see each other.
Right, gives you a reason to kind of brave the cold for sure. Do you have a favorite book or movie?
Favorite book. Well, I've been reading so many textbooks. I guess the last one that I used to like that Da Vinci Code stuff, maybe a little more schlocky than anything else.
Where would you love to travel to next, or a place that you've been that you really enjoyed your trip to?
Anywhere away from home. So away from work, away from home, away from your headaches. We joke about it, but we drive up sometimes to Fargo, North Dakota, and that could be a fun place to go if you have that R&R time.
How far is it to Fargo from Omaha?
It's not bad. It's only 5.5 hours. So I practice up there, and I still do a little outreach now and again. I'm probably going to have to give that up just because of the distance, but
right.
It's not that bad.
Nice. Did you always know that you wanted to be a doctor or a physician of some type? And where did that passion for medicine come from?
Well, I didn't always know I wanted to be a doctor. I kind of was in the computer science direction early on. And it's funny, that's 30 plus years ago. Everything we still did on computer cards. I wish I kind of did do that. Maybe I'd be the new leader of Apple or something. But I was a little bit scared of that. And I did love helping people. And, we come from a blue-collar working family, so just going to school, doing well in school, it kind of seemed like a natural transition. I was a little dismayed because I credit the people that do the jobs in medicine that I don't do, and I just feel very fortunate that I kind of linked into what I do now and what I love to do.
That's a great answer. I love that. Can you tell us a little bit about your education and experience kind of through the years and kind of what led you to orthopedics specifically?
Sure. So like I said, I grew up in Canada, so I trained within the Canadian system. I guess I'm fortunate in a way because, our healthcare and our education is subsidized. We pay a lot of taxes, though, so we should have subsidized healthcare and education. And so I finished up in Vancouver, British Columbia, and Winnipeg, Manitoba. And then once you're done with orthopedics, you have that opportunity to subspecialize. And that's where I subspecialized in Arizona Center for Joint Replacement. My leader there was the first doctor in the United States to ever actually put in a hip replacement. So there were only about 3 or 4 guys who were allowed to do that. So a great experience in history with that. And then I did another fellowship, we call it, trained at Rush Presbyterian in Chicago for another year with one of kind of the gurus of joint arthroplasty. And from that, obviously, during that whole course, I fell in love with what I do, which is specifically joint arthroplasty of the hip and knee. I don't do a lot of that here at CAS from a revision perspective, but I do a lot of the redos, the unfortunate people that have infections, fractures, things like that.
Gotcha. How has your experience over the years, because I was kind of checking you out a little bit on social media and the internet and stuff, you spent over 20 years not only performing those surgeries and stuff like that, but teaching advanced knee replacement techniques and kind of helping improve the implants themselves with different medical device companies and stuff like that. How has that experience shaped the way that you approach procedures like the Jiffy Knee? And why is it so important for you to continue to train surgeons? And do you still train surgeons at all?
Yeah, so I still continue to train surgeons. I'm part of our professional group. I'm kind of on the editorial board for our professional journal. I think it comes down to the passion, and with the passion of it all, you do learn. And I guess that whole thing about even seeing those unfortunate people with those complications, you have that opportunity to learn what not to do versus what to do. So in addition to that, you're right, with teaching, being part of our residence program at University of North Dakota, University of Nebraska at Creighton, you see the young minds kind of developing. But in addition to that, we also train fully fledged orthopedic surgeons. And I thought I'd get kind of bored of that and tired of it, but it's funny how the science and the profession keeps evolving. So you learn as much from them, as much as you teach, and I think that's what then gives us that impetus to redesign new implants, to redesign new techniques, and to make the patient's experience better.
It's never boring, is it?
No.
Right? Always changing. At high level, what is the difference between a total knee replacement and a partial knee replacement?
So that's a great question. And your knee is actually different than the hip. The hip's got one joint and you replace it and that's it. Whereas the knee's got 3 different compartments. It's got the kneecap part, and that's a separate joint. And then you have the inside part of your knee and the outside part. So there's 3 separate compartments of your knee. And with that go all the ligaments to kind of help, we call it kinematic, or the motion of your knee, the function of your knee through a full range of activities. So with a partial replacement, you can just replace one of those 3 compartments, the kneecap compartment alone, the inside compartment alone, or the outside compartment alone. Now, that's a great opportunity for you if you just have isolated disease. And the reason why we like doing those is the recovery is far, far easier, but the functional result is much better by not removing the ligaments and not doing as much dissection. And it's a much more normal feeling knee. Now, if more than one of those compartments are involved, 2 or 3, then you get that total knee replacement. The total knee replacement is probably one of the most common operations out of all these different procedures we talked about. It's a great operation as long as your disease is throughout your entire knee. And to be honest, as long as the right implant is chosen and as long as your knee's balanced. And that's why we're looking at these new techniques such as Jiffy, and that's why Cass has even been involved in obtaining robotic options to kind of help us balance knees, get it closer, get it better to what God gave you, so to speak.
Starting out as an orthopedic surgeon, you probably have done lots of traditional knee replacements. When and why did you start doing Jiffy knee surgeries? And was there a moment or a patient experience that made you kind of be like, oh, this is different. This is kind of a game changer,
Well, the knee is a very delicate joint. As I said, it's those 3 compartments. It's not just a simple hinge. It's got complex motion to it. So, doing knee replacements over the last 30 years and designing implants, we've refined the implants. We've refined how we put it in with instrumentation. But as I said earlier, it's not exactly what God gave you. And people will sometimes say it just doesn't feel like a normal knee. On top of that, as I said, I'm a revision guy, so I see a lot of people who have joint replacements who are unhappy. And you look at the x-ray, the surgeon's done a great job, everything's kind of where it's supposed to be. But as I said, it's not what God gave you. And that patient wants to do all these aggressive activities, whether it's running, heavy squatting activities, skiing, things like that. And if you damage more of these tissues and you can't kind of replace them or put them back where they're supposed to be, then it just doesn't feel right. And so that's what kind of led us to this Jiffy approach, along with the robotics, along with partial replacements to get it closer to this more normal functioning knee.
That kind of leads us right into our next point there. What makes the Jiffy knee approach different from a traditional knee replacement surgery?
So it's not just the approach, it's the whole kind of perspective of, what the patient's going to experience from before surgery, during surgery, and after surgery. And we're trying to make that as seamless and as atraumatic to the patient as possible. Less trauma, less damage to the patient means faster, quicker recoveries, but a more functional knee replacement. So the Jiffy takes advantage of the point of going kind of below your muscle margin. So you have to get into the knee, you have to be able to see what you need to do in the knee. But this special approach, which is quite proprietary, and again, learning from my friends in that this approach, it really doesn't put the patient at risk, but only gives the benefit of keeping their muscles intact while being able to see and do everything that you want to get that knee replacement in correctly.
Gotcha. I had watched some of the videos on the Jiffy Knee website and stuff. It looks like it gives, like you said, the same interior procedure with the knee and everything itself is done, but you don't have to cut those muscles and everything and stitch them back together and stuff like that. Is that kind of the gist of it a little bit?
Absolutely. And to fine-tune that a little bit more, we're now big proponents of the robotic options. So not only do we have the benefit of not damaging the muscles with the Jiffy approach, but the robot and the robotic balancing that occurs really fine-tunes that knee to get it as close to where we want it to be for that specific patient.
Kind of a patient-by-patient approach there.
Couldn't say it any better.
Awesome. Can you walk us through what the day of a surgery looks like for a patient? Kind of like beginning to end.
So, their experience probably doesn't begin exactly that day because there's a lot of our family here that kind of coaches them through what to expect. So it's that preoperative kind of preparedness to know what you're getting yourself into. So whether it's pain med planning, physical therapy planning, what to experience at home, what to experience even during that day, medications, all that type of stuff. So the patient will have that kind of armamentarium in their wallet already and kind of know what they're going to be going through. That day they come into the hospital, we get them ready, get them rolling for surgery. A very important part is preemptive pain control. So we work closely with our anesthesia team to provide the appropriate blocks so that patients don't have severe pain post-operatively, and so that they can kind of manage after we've done what we need to do. So once they're prepared, yes, they get their anesthetic, they come into the OR, we perform the approach, the robot gets aligned, we go through the step-by-step process of getting the knee, and then they end up in the post-op recovery room. Historically, when I started my training 30 years ago, people would stay in for 7 to 14 days after a joint replacement. And so now our recovery team and nurses are ready there as soon as the anesthetics allowing the patient so that they can move, we get them up. And we want those patients to be safe, getting to and from the toilet, up and down maybe a couple stairs, in and out of bed. And if their pain's controlled and they're feeling good, that's it. And they're ready to go home. The whole process, though, does take time. You're going to keep improving, and that's where I get a little nervous of people thinking they're going to be normal that day. It's like any cut you have. I've been doing my gardening this weekend, and, everything's still got to heal. And if anything, we like to maybe sometimes tell people they got to tone it down because they will feel good enough to do their aggressive activities, but everything's still got to heal. And then on top of that, you have to rebuild your endurance. So remember, if you're arthritic, you can't do everything you want to do day by day. So once you're having your knee and once you're feeling better, not only do you have to recover from what we do to you, but you have to recover from your pre-op status. So if you're not able to, let's say, go for your 3-mile walk or hike or bike, you got to work your way up to that. So you'll see significant gains over the few months after surgery. But yeah, by, those first couple of weeks, you probably should be able to do your day-to-day activities relatively easy without concern.
And then kind of ramp back up to where you were before.
Correct.
Very cool. What is a typical recovery for someone after a Jiffy Knee surgery? Are there any differences with physical therapy treatments and things like that compared to traditional knee replacements? I know, like you said, with a traditional one, they would be in the hospital doing inpatient physical therapy. And then if they're not here for that, how is that different, I guess?
Yeah, so I kind of alluded to that a little bit, but historically, just with what we would do to a patient, we cause a lot of damage. If you're making cuts, doing a lot of releases, things like that, that causes an inflammatory response. So, the leg is angry, bruised. And again, with more dissection, there's more trauma. With more trauma, there's potentially more scarring. So despite all that, we'd kind of have to whip the patient into doing activities because we're worried about them getting too stiff. The beauty about this is that the less trauma you do to a patient, the less aggressive you have to be. So a patient will know if they're not hurting, everyone's coming in so they can go walking, biking, hiking, all that type of stuff. So that's kind of the beauty of we really don't have to push through the pain. And saying that means less pain meds. If anything, the nice thing is because there's no scarring, because there's less inflammation, I shouldn't say less of everything, we're still cutting into you. But because there's less trauma, as I said earlier, you can kind of tone it down. You don't have to kind of keep whipping that patient to do stuff. Because our concern is a patient who gets a replacement, again, as being a revision surgeon, we see a lot of knees that come in, x-rays look great, but the patient's horrifically stiff. And if you're too stiff, you can't even go down a stair. You can't sit in a car. Trying to pick something off the ground becomes extremely difficult. So that's been this impetus to go to the Jiffy and the impetus to go to the robotic option also.
Gotcha. That reduced downtime, reducing the stiffness post-op.
Right.
We touched on this a little bit too, but let's kind of talk about pain as well. So with any major surgery, pain is one of the biggest concerns for patients. You kind of talked about what you do before with the anesthesiology team and what is done kind of after surgery to manage that pain, and how do you kind of set patient expectations for recovery?
So there's a lot of good modalities, that we didn't take kind of great care with before, and this whole Jiffy protocol is kind of package this all together. So even here at CAS, we have this opportunity of doing iovera. So 3 weeks prior to surgery, we almost start preparing people for their recovery and blocking pain with the iovera treatments, which has been something of an asset that you guys have here that certain places do not have, can be instituted. And then, as I said, the type of anesthetic is critical, how we block the patient for after the surgery, while in surgery. All these can help with pain and reduce pain, but it still goes down to the procedure also. Less trauma, less damage means less pain for the patient, and that's kind of the big push with Jiffy.
Awesome. Who is and who isn't a good candidate for this procedure?
Well, obviously you have to fail all conservative measures. So, we don't, I got some knee pain, but the last thing I want is a knee replacement at this stage. I might come down to that. The great thing about the Jiffy and the great thing now about these partial and totals, we really are able to customize that to the patient. So people might get a unicompartmental or a partial knee replacement with the Jiffy approach. They might need a complete knee replacement with the Jiffy approach. And even within complete joint replacements, there's a whole different type of total knee replacement for that patient. So everyone's a candidate for Jiffy as long as you need a replacement. And so it's not a magic be-all and end-all. We really want you to have bone-on-bone findings. We want you to fail conservative measures. And it's not just treating the x-ray. We look at what patients can and can't do before their surgery so that we don't fail their expectations and so that they only, do well after the surgery.
What are some common misconceptions or things that patients might not be expecting about having knee replacement surgery?
Well, it doesn't make us 21. I wish it did because I'd get mine done.
Right?
The biggest concern about total knee replacements is that we still have to remove your cruciate ligaments. And that can produce a little bit of an instability within the knee, and that's why we look at partial knee replacements, because those keep all your ligaments together. Even if you need a total, that's why we talked about balancing of your knee as being so critical with the robot and with the Jiffy approach. So the problem with that is, trying to be 21. And yeah, with your total knee, are you going to play tackle football? Probably not. But can you do your pickleball? Can you bike? Can you do your hiking up in the mountains? Yes. Can you swim? Yes. Can you downhill ski? Probably on blues. But as I said, we still want to match that to what your disease is. We saw Lindsey Vonn, so to speak, and she was an Olympic caliber downhill skier with a partial replacement. Now, she ripped her cruciate ligament, which was another story, but she probably wouldn't have been able to do that aggressive activity with a total. So if you're disabled, you're going to appreciate any of these options that we've presented today.
So kind of just to touch on that super quick, we can cut this out too if we want to about Lindsey Vonn and stuff. But I was just super curious as a orthopedic surgeon like yourself, to see her attempt that with that ligament kind of compromised a little bit. Is that something that you're like, oh my gosh, why would you do that? Or
well, she was good with the partial.
Okay.
So the partial replacement she was doing great with. The problem is after that partial, she then tore her cruciate ligament. So it wasn't so much the partial, it was how important her cruciate ligament is, and that's probably led to her downfall because that cruciate ligament gives inherent stability to the knee, and when you don't have it to provide that caliber of sporting activity is just too much to ask.
Any advice that you would give to patients before surgery to kind of help them recover better, faster, or have a better outcome overall once they're done with this procedure?
I think the most important thing is have a good rapport with your physician or your physician assistant or APP, we call it, associated provider. Understand what your problem is, understand what all your different options are, and kind of work your way through it. It is, unfortunately, a long, ongoing process. We see people very early in their disease, which is frustrating for them because, they just can't do everything they want to do. But the question is, are they really at that point where they need to have their joint replaced? There's lots of great conservative measures with, different types of injections, physical therapy, even good anti-inflammatories. Because sometimes if you can get just over those bouts, then you go back to where you were. So have a relationship with your doctor or doctor assistant, work your way through it, and then as a team, you guys will decide when it is and is not time to take that bigger jump. And then have a good outcome with it because you'll understand the whole kind of path or trip that you're going to have to take from start to finish.
Don't just jump right to that replacement surgery, but try the other things first. So if someone was listening to this podcast and they're debating about whether or not they should get their knee replaced, what would you tell them? Kind of like if they've gone through, for example, like what we just talked about, they're kind of outlined. If they were like, should I do this or should I not? Their doctor's kind of recommending it. What would you say to them?
If your doctor's recommending it, I think, I probably would go forward with that. Just be aware, when you're arthritic, it's not always just your knee. And I just saw a patient today who had knee problems and it was their hip. Or we see problems with the knee that could be from your back. And so that's where it's very important to kind of stick with that relationship so that you know what type of benefit you are going to have and to make sure you avoid complications. Complications are extraordinarily low, and maybe I'm talking it from the other side, being a redo joint replacement guy, but they can be catastrophic. So being sure that the protocols are followed, that you understand what you're getting into, that all other potential issues are being dealt with, will ensure the best outcome for you. So have a good relationship with your orthopedic surgeon.
Absolutely. How often are you here at Cass Health? And then what services do you offer here? Kind of outline that for me.
Well, our team is from MD West 1 in Omaha and Council Bluffs. We have a great team of specific docs with specific subspecialties. So there's someone here at Cass Health almost every day. And that includes, from nose to toes, so to speak, for orthopedic care. I'm specifically involved in lower extremity joint reconstruction, so that's with your hip and knee. I'm here essentially weekly. And as I said, that gives us the opportunity to see the progress of our patients, to make sure we're kind of handling their issues and making the best choices, with them involved to get the best outcomes possible.
If someone listens to this and they're interested in maybe scheduling an appointment with you, can they just call our surgery clinic to schedule with you? Or
Yeah, call Cass Health, speak even with your family provider, but at any time we'd be happy to see you and take care of you.
Thank you so much for coming on the podcast and chatting about Jiffy Knee with us today. It was great to kind of learn more about you and about this procedure that's coming to Cass Health. So thank you.
Thanks a lot, Carter.